So my name is Augmenting. I'm a board certified psychiatrist, and I've helped over 200 PMHNPs and FNPs gain clinical confidence in their psychiatric diagnosis skills, treatment skills, and actually helping patients get better results. So in this video, I'm going to be covering how to taper benzos. And this is a notorious problem that a lot of patients really struggle with. And I remember the first time I experienced this, I was in residency, and there's a psychiatrist in the community who had retired. So our residency clinic got a lot of the old patients of his. And I remember I had this patient who was on Xanax, 1 milligram, 4 times a day. And so I was like, geez Louise. And so she was an older patient. She was like in her 70s. And so was starting to develop some slowing. And so I was like, okay, like we need to make sure that we get this benzos like addressed. And so she had never really tried to come off of it before, and so it was really hard. And so I had to learn all about, okay, how do I taper a benzo and how can I work with her to get her off? And so with her, it took us a full year to do it. It wasn't like an easy process by any means, but in the end, she was able to come off, and thankfully, it made a huge difference for her. So I have two methods that I like to approach this. So so the patient was on Xanax, right? And so what you have to understand actually is the different half-lives of the different benzos. So let's say short half-life. So Xanax has a short half-life, and Ativan does. Like these ones last about 4 to 6-ish hours per se. And then there's long half-life. And these are Klonopin and Valium, diazepam. And so the reason I mention it is because the longer half-life ones are easier to taper than the shorter half-life because you end up having more withdrawal with the shorter half-life one. So there's two different methods that you can use. So one is that you can just go down on the medication on its own. So taper med thereon. So for example, my patient was on Xanax 4 times a day, right? So I'll write so Xanax, 1 milligram, 1 milligram, 1 milligram, 1 milligram. And so what I did was slowly we would just start adjusting the doses in time intervals. So for example, like, this one would continue at 1, this one would continue at 1, this one made 0.75, and then this one continued at 1, and then keep on going. So then we could do this one at 1, this one at 0.75, this one at 0.75, this one at 1, and then this one at 0.75, then you maintain that. And then eventually you get down to 0.75, 0.75, 0.75, and then 0.75. So this is one method that you can use, right? Where you just start going down the dose slowly. And it can work if you don't want complexity or the patient doesn't want to use the second method, which involves changing, and I'll get to that. So for example, with this patient, what I had actually tried was to switch her to Klonopin and try to come off that, but she just did not respond well to the Klonopin. She did not like it. She really kind of wanted her Xanax. She just felt like that worked better for her. So this was a more sustainable approach for her. But now the question is, okay, what's the time interval, right? What's the time interval between here and here? So it depends on how long the patient has been on it. So if they haven't been on it for long, like let's say 6 months, then you could do, for example, a week, right? One week, 2 weeks, etc., between intervals. But let's say they've on it for years and years and years, you might need to spread it out further. So you could do instead 1 month, 2 months. Basically, the interval is arbitrary. You have to kind of guesstimate it based off of how long they've been on it and but more importantly, how well the patient responds. So some patients, they may have only been on the medication for a couple months, yet they may need a slow taper because they don't do well coming off of it. Whereas other patients may have been on the medication for years and years, but they might be able to come off relatively quickly just because they don't have any withdrawal symptoms. It's the hardest 2 points of withdrawal are when you start it and when you end it. So starting is hard. Like when you just start to get off, it's hard because that's a change from their baseline. So they might not be used to that. So it's always a shock the first time. And then ending it can be hard. So let's say the patient's on 0.25, 0.25, 0.25, 0.25, and then they start to go to 0 to 0 to 0.25, 0.25. Then because now they changed, the percentage change is greater, right? So every change here is like 25%. Whereas here, the change is not that much, going down from 1 to 0.75. So that's only a quarter. Whereas this is 25% of their entire total dosage. Whereas this is like a fraction of the total dose. So that's why it's coming off of the end is harder. So you might need to go slower here. You might need to go slower here or smaller intervals. So for example, here, I might go to 0.125. So just acknowledge that it's not like a standard. You don't just pick one thing and go. You flex and you adapt based on how the patient is responding. That's the most important thing. But then the second method, which can make it easier for a lot of cases, is convert to longer half-life. So this is what I was alluding to before. So with her, I tried to convert to Klonopin, but she just did not respond well to that. So we had to go back to the Xanax. So what you can do is you can direct switch to equivalent dose and taper that. So 1 milligram Xanax equals 1 milligram Klonopin equals 2 milligrams Ativan equals 10 milligrams Valium. So for example, in this case, we went from 4 milligrams of total Xanax to 4 milligrams of Klonopin. So that is also equal to 8 milligrams of Ativan, and that would be 40 milligrams of Valium. But then once you're on the 1 milligram of Klonopin or 1 milligram or the Valium, the equivalent doses, then you can start tapering these. And these are a lot easier to come off of than the Xanax is because it's got a long half-life, so the change in blood concentration is a lot less. But, you have issues with that the patient may not want to switch. The patient may not respond just like anecdotally to these ones, just due to their own body chemistry compared to one of these. Those would be the main two reasons. So this definitely is a viable approach that can work, but it may not work for everybody. So that case, you have to go to this approach. And then number 3, what you can also do is augment to make taper easier. So you can augment with like anxiety stuff. So SSRIs you could use as an augmentation. For example, you can use supplements such as L-theanine, because these are calming, help with anxiety. Magnesium glycinate, ashwagandha. All of these supplements, they can help to make that taper easier. But ultimately, you have to help the patient understand that it's a long-term process, tapering, and it won't just happen immediately. So I hope this guide is helpful. And this is stuff that we go into in depth in our PMHNP and FNP coach psychiatry coaching program. So that's where my students will ask me questions. We have real live Q&A calls every week. We have a community where people can post their cases. So people will post their cases, ask their questions, and that's where I will give my advice and feedback on how I would approach it as a psychiatrist. So I definitely recommend checking that out. I mean, otherwise, I will see you in the next video.